The hopes that you bring, the dreams that you share, the pleasure you get when you know that we care. The faith that you place, the trust that we share, the joy in your heart when you know that we care. You before we at USV, you before we at USV.
USV, your reliable healthcare partner.
Hello, welcome to a very special program on heart disease. We call it a Halt Heart Attacks. We have a very esteemed panel today to discuss this, and let me introduce the panel to you. On my starting from my left side is Dr. Narasimhan. Dr. Narasimhan is Director of Care Group of Hospitals based in Hyderabad, and then is Dr. Rajiv Agarwal. Dr. Rajiv Agarwal is Director of Max Smart Hospital, New Delhi, and then Dr. Thomas Alexander. He is the Director Cardiology at Kovai Medical Center, Coimbatore, and then we have Dr. Anil Dhal. Dr. Anil Dhal is Director of Venkateshwara Cardiology Institute in New Delhi. Let me start with Dr. Narasimhan. Dr. Narasimhan, what is exactly heart disease?
Heart disease is not a single disease entity. You can have heart disease right from childhood, where some unfortunate children are born with a heart disease called congenital heart disease. But the vast majority of people who suffer from heart disease are people who have what is known as acquired heart disease, either because of diabetes, hypertension. As you all know, heart is just a muscular pump. When the pump becomes inefficient, you develop a condition called heart failure. Similarly, for this pump to work in a coordinated manner, you need an electrical system to activate the heart. When the electrical activation is defective, people can either develop sudden cardiac death, a very slow heartbeat, or very rapid heartbeat. These are called arrhythmias. So there are different types of heart diseases.
Dr. Rajiv, how much is the disease in India, prevalence of the disease, and would you compare it to the rest of the world, particularly Western civilization?
Well, there are various estimates of this, and cardiovascular disease, which predominantly includes heart attack, has been well established as the #1 killer all across India. When we talk of numbers, then the Registrar General of India has done surveys, and this says that in the year 2010 to 2013, approximately 32% of all adult deaths occurred due to coronary heart disease, that is to say due to heart attack. So when we compare this on the world stage, then we look at data which is multinational, and so there is what is called the Global Burden of Disease Study. And even that says that if there are an estimated 9 million deaths due to heart attack in a year globally, then 2 million of them are in India. That is approximately a quarter, which is far more than the Indian population.
Well, these are disturbing figures, and may I ask Dr. Thomas that why Indians are particularly at a higher risk as compared to the rest of the world?
I think there are three factors that we need to consider, and as Rajiv just mentioned, Indians have a 3 to 4 times higher prevalence of heart disease as compared to other ethnic groups. So there is clearly a genetic predisposition among Indians to develop this, and there are many reasons that are attributed to this. The second is the traditional risk factors that are responsible for heart disease and heart attacks. Now, the effect of these traditional risk factors are much more in Indians as compared to other populations. If you look at the cholesterol abnormalities, again, this is typical for Indian populations, where you have triglycerides which are very high and the good cholesterols which are very low, and this develops into what we call metabolic syndrome and thereby to heart disease. So the traditional risk factors have a much greater effect on the Indian population. The third factor is that of environment. There has been a tremendous both demographic as well as epidemiological transition in the Indian population, a migration from rural to urban populations, And as a result of this, there is lifestyle changes, there's change in dietary habits from organic food to processed foods, lack of exercise and increase in stress, all of this contributing to heart disease. Add to this is the recent data that we have that air pollution and increased use of pesticides is also contributing to heart disease. Now, when you put all these three factors and then add to that the lack of resources that many of our people have, the lack of systems of care in place to treat heart disease, you have a disease of epidemic proportions.
Let's go to Dr. Dhal. Dr. Dhal, you think there are differences in the prevalence of heart disease in rural versus urban populations?
See, the heart disease prevalence per se has increased exponentially. We can say that it is from 1960s, where we had population estimates of prevalence being 2%, it has grown almost 400 times in the last 4 or 5 decades, which is truly exponential. Yes, the prevalence data which we have from the community tell us that 2 to 7% prevalence is there in rural areas as compared to 7 to 13% prevalence in urban areas. But we also must realize that there is a lot of migration of people from their rural habitation to urban or semi-urban areas. Also, some urban areas where people are clustered closely together and where there is a lot of risk factors, as Dr. Alexander brought out, with a lot of psychosocial stresses. You can have like a study from South Chennai which said that 38.6% prevalence was noted of coronary artery disease. This doesn't even extend only to a division between urban and rural areas. When we were undergraduate students, we used to think that coronary artery disease is a disease of the affluent. Today, we realize from all the data that is available that the socially and economically less privileged have far more disease than was earlier thought.
Let me ask very important question to Dr. Narasimhan. What is actually heart attack? How one should suspect that heart attack is coming?
Heart attack is sudden blockage of blood flow to the heart, and contrary to the popular belief, it's not an acute chest pain. What happens is a dull discomfort very often, as though someone is pressing on the chest, and very often this can be very atypical. The pain can be radiating to the shoulder, the jaw or the neck. And a very common misconception is when a person has chest discomfort with some abdominal pain and nausea, it's mistaken as a gas problem and they keep popping on antacids or one of these drugs to suppress the symptom. And this is a common manifestation of heart disease. Unexplained sudden sweating, sudden onset of breathlessness, heart racing very fast or feeling dizzy. These are all common manifestations. What is sad is about 20 to 30% of heart disease, heart attacks are quite silent. They don't even recognize that there's been a heart attack.
Particularly in diabetes.
Yes.
I would like to emphasize only one thing, that when you have a upper abdominal symptoms in the tummy, it is not a good idea to assume that this is gas. Somehow this is common in India, particularly if these symptoms are occurring first time, they have not been there before. It is always it is a good idea to go to a nearby physician and get an ECG done rather than missing a heart attack, because we see this very commonly in India. Okay, let me come to Dr. Rajiv Agarwal. Dr. Rajiv, how does one treat heart attack?
I think it's very important for us to educate the general public about this because every minute counts when the person has a heart attack. And the proper treatment of heart attack rests on 3 pillars. The first one has been just talked about, and that is early diagnosis. That cannot be emphasized too much, because time is muscle and you're losing heart muscle with every minute which is lost. Secondly, what is the first aid which the person can take at home, and thirdly, what will the doctor do and how will you get the blood vessel opened up. So, after the early diagnosis, then at home the person can take a tablet of aspirin. This could preferably be crushed and taken with half a glass of water for fast action. If he is having chest pain and sorbitrate tablet is available, then sorbitrate tablet can be taken under the tongue, and beyond that get to the hospital quickly. You should have a social support system, or you should know where to get an ambulance from so that you can get to the hospital. In the hospital, doctor will do various measures in order to open up that blood vessel, and that includes either a clot dissolving medicine, which we call thrombolytic therapy, or in case a cath lab is available, then a primary angioplasty would be done in order to open up the blood vessel.
Thank you very much, gentlemen. We have to have a small break. After the break, we will discuss many more important aspects on heart disease.
The hopes that you bring, the dreams that you share, the pleasure you get when you know that we care, the faith that you place, the trust that we share, the joy in your heart when you know that we care. You before we, as USP, you before we, as USP.
USV, your reliable healthcare partner.
The hopes that you bring, the dreams that you share, the pleasure you get when you know that we care, the faith that you place, the trust that we share, the joy in your heart when you know that we care. You before we, as USP, you before we, as USP.
USV, your reliable healthcare partner.
Let me ask Dr. Thomas, what is your expertise in developing a pilot project of STEMI in India, in Tamil Nadu?
Well, I think we've all discussed how important time is in managing heart attacks. Usually we would say you need to open the blocked vessel within 3 hours of onset of symptoms to get the maximum benefit. Now, in advanced countries like the US or Europe, you just have to call a number 911 and immediately an ambulance arrives and takes you to the appropriate hospital. Now, no such system exists in India, and what we did in Tamil Nadu is to develop a very unique model, and that's called the STEMI India model, which is looking at developing a system of care in India. Now, this is a hub and spoke model that we created, where a hub hospital, usually located in a metro city, is connected to multiple smaller hospitals which are located in rural areas. Now, if a patient comes to the urban center or the hub hospital, he gets a primary angioplasty. Well, if he goes to the spoke hospitals, he will get thrombolysis or the clot dissolving medication and then is transported to complete the procedure in the hub hospital. In fact, in the study that we've just published, and the study was done with support of the Indian Council of Medical Research, we were able to show a 19% reduction in mortality in a brief period of 9 months. Now, there are 3 critical aspects which were there in this program that we developed. One was we linked it to the below poverty level insurance that the state government has rolled out in the state. Now, what it did is to develop, to ensure that every patient, irrespective of their ability to pay, was able to access this system of care and get state-of-the-art treatment for the heart attack. The second important thing was that we linked it to the 108 or the EMRI ambulance services. And this ensured that the patient could be picked up at the point he had chest pain, and the treatment would commence at that point in time, and they would be moved to the appropriate hospital rather than waste time in some other hospital. The third thing that we developed is to use technology. Along with our technology collaborators, we were able to develop a device where we could do an ECG even at the patient's home, transmit it to a cardiologist, confirm that it's a heart attack, and then move this patient appropriately for treatment. So I think getting the system in place, we're now hopeful that we can reproduce this system in other states in the country.
Dr. Dhal, what are the risk factors to develop heart disease, particularly focus on India?
We knew for many years that the incidence of heart disease rose in Indians. Like I said earlier, we had studies from all over the world which told us the same. But the InterHeart data, which came out a few years ago, which evaluated people in 52 countries, 30,000 patients, people presenting with first heart attacks, actually gave more importance to the traditional risk factors, because till this time we were thinking there would be some out of the box risk factors which would be relevant. So if I were to classify risk factors, we would take them, even the traditional risk factors, they would be those which are not modifiable. For example, with the age, we do get increase in amount of heart attacks. We know that chronological and biological age is an important number. Then gender. For example, females during reproductive age group are protected unless, of course, if they smoke or they have diabetes or they take oral contraception or they have hypertension, then they lose their protection. And thirdly, strong family history can be very important. So if somebody has strong family history, our index of suspicion goes up. These are things which you cannot modify, but there are many things which you can modify. One of them is tobacco abuse, and this is something which we should all look at very, very seriously, because it's a very important social problem which is becoming a very important risk factor. Then is the prevalence of diabetes. We know that we are the world capital of diabetes. Look at high blood pressure. People do not even know that they have high blood pressure, and less than 1/4 of patients in India who have high blood pressure, whether in the urban or rural scenario, get their blood pressures controlled to targets. What about high cholesterol? It is very relevant, but that if you have higher cholesterol numbers, then this comes 1/3 from your diet, 2/3 from what the body makes itself. It becomes very relevant. Apart from that, physical inactivity, obesity, these are important factors. There are some newer risk factors which are emerging. Psychosocial stresses, especially sleep disorders, air pollution, use of pesticides. These are some things which are relevant today and which we have to actually consider seriously when we evaluate risk factors for heart disease.
Dr. Narasimhan, it is proven that a lot can be done by prevention, particularly it has been proved in Western civilization. So, would you please tell us how much heart disease and how we can prevent the heart attacks?
Whether you're rich or poor, please remember, by putting an expensive stent or undergoing surgery, you cannot prevent a heart attack. What happens is almost 40% of patients who have the heart attack die during the first episode of heart attack. They don't even reach the hospital. And another 10 to 20% of these patients don't even realize they have had a heart attack. As you have heard, time is muscle. So whether you open the the vessel after about 6 hours or 8 hours, it doesn't really make a difference to the patient. So time is muscle. You need to act very, very immediately. And for this, prevention is the key. Now, there are simple things that you can change in your lifestyle which can help to prevent a heart attack. For example, if you're a smoker or if you're chewing tobacco, please stop it. If you cannot stop it, take a medical opinion. There are very efficient ways of withdrawal from tobacco. Second, start exercising. Every single day, just like you go and brush your teeth, exercise should become a part of your daily routine. Allocate about 30 minutes of your time for exercise. If you are very young, start going for a jog or going for the gym, and vigorous physical activity is allowed. In middle age group, we would recommend brisk walking. As you become older, you may have to think of other options like doing stretching exercises at home, yoga, and so on and so forth. The third is about stress, because stress is an increasing factor in the country, and simple exercises like yoga, meditation, or prayer, just allocate some 10 or 20 minutes every day for this. Cut down on sugar and salt in the diet. As far as possible, cut down sugar, cut down salt, avoid processed food as much as possible.
Rajiv, very briefly, would you tell us why very young people in India get heart attacks?
If you look at the data, then Indians tend to get heart attack about a decade younger than in the Western population. So that is one fact. The second fact is that heart disease is primarily a lifestyle issue. We do have genetic predisposing factors, and Indians maybe have somewhat worse genes than in other countries, but primarily it is our lifestyle which is causing this epidemic of premature heart disease, and therefore we have to look at the lifestyle in order to prevent it also. So with increasing affluence, increasing urbanization, we have tended to have richer food, we tend to exercise less, our body weight is going up, especially the central obesity, the tummy going out. There is increasing smoking. India is becoming the diabetes capital of the world. There is increased psychosocial stress, which we all are having, plus the effect of air pollution, etc. So, the genetic factors plus the worsening lifestyle is creating a double whammy.
Dr. Dhal, briefly again, what are the complications of heart attack?
I think very simply, heart attacks kill.
Right.
And that is the most important complication. Many people, as Dr. Narasimhan pointed out, do not even reach the hospital. They have something called a ventricular fibrillation, wherein the heart just arrests, it starts fluttering and beating very fast, and because of an electrical abnormality in the people just die. And for this, we must educate our public on bystander resuscitation and also have more automatic external defibrillators available in public places so that people can be resuscitated. But classically, we divide the complications of a heart attack into two major groups. One are electrical, which include abnormal rhythms like ventricular fibrillation, ventricular tachycardia, which can be a precursor to ventricular fibrillation, and for which we may need to give shock boxes later to prevent sudden death, and other abnormal rhythms. During a heart attack, you can have slow rhythms which may require pacemaker implantations, and so on and so forth. You can get atrial fibrillation. There can also be embolic complications, because once heart attacks happen, then there can be clots which can form in the heart cavity, which can later go to the brain, and this can cause strokes. There can also be psychosocial complications.
Dr. Narasimhan, very pertinent question to you. What is the kind of economic burden to the family and the society of heart because of the heart attacks?
Economic burden is tremendous for the family, because we always try to quantify economic burden in terms of dollars or rupees spent. But for that family, if the patient dies, it's a permanent loss of life. So please understand that most of Indians develop heart attack at between the age of 30 and 50. And that's when they're at the best of their earning capacity, peak of their career, and suddenly a heart attack slows them down, or patients die of sudden cardiac death. And it's a permanent disability for the family. The earning member is gone, the son loses the father, and completely the family is devastated. So the economic burden cannot be quantified purely in terms of rupees or dollars.
Dr. Thomas, as far as I understand, in our country, there is no structured program of prevention of heart disease in any state, including Delhi. Neither there is any structured program of how to handle a heart attack. Now, with your experience in Tamil Nadu, you see any progress in our country to develop such kind of programs?
Well, I think it's interesting that you asked this question, because recently we published this data from Tamil Nadu, and we showed a 19% reduction in mortality, but we also showed, we did an economic modeling of this system of care that we had developed, and we showed that for every rupee that is spent to develop this system, society would save 4 rupees. So we've shown not just mortality benefit, we're also showing economic benefit in setting up this system of care. So after we published this, the Indian Council of Medical Research, which had partly funded this, and the NCD cell of the Union Health Ministry called a meeting, a dissemination meeting in Delhi. This was in January, when 18 state governments attended this meeting, and the details of this system of care were disseminated to them, telling them how to develop a similar system in their state. And as a result of this meeting, now 3 states are in the process of starting a heart attack program in their states: Goa, Karnataka and Telangana, and 3 other states are in the early stages: Andhra, Tamil Nadu and Kerala. So I think gradually we're going to see a system of care to manage heart attacks in India based on this model, which is now called the STEMI India model. Interestingly, there are 3 countries from Africa which have now asked us to help them to start a very similar system of care. And the World Heart Federation, in fact, has said that this system of care should be the model for low and middle income countries.
Well, thank you very much, gentlemen, for a very nice discussion. It is very clear that in India today, 3 major killers are diabetes, heart disease and hypertension, and all the 3 diseases, they are lifestyle diseases, and a lot can be prevented by changing the lifestyle. There is another thing to realize, that prevention of heart disease and heart attacks to a lot of extent is possible And number 2, that a prompt diagnosis and a early treatment of heart attack can lead to a lot of reduction in mortality and better quality of life in our people. Thank you very much.